All right, well, let's go ahead and get kicked off here. Welcome to our first session in MPN Pathways, Empowered Voices and Research Certification Program. We're so glad to have all of you here, and we are thrilled to be able to provide education and ways MPN patients and caregivers can be research advocates. For those of you who have not had the pleasure of connecting with, my name is Sarah Douglas, and I am the Associate Director of Patient Engagement at MPN Research Foundation. Just a little background on me. I am a hematology oncology nurse. I'm very passionate about educating patients about the disease, their treatment options, clinical trials, up and coming research, and really the importance of advocating for themselves. So let's continue to stay connected. I'm here for you as you kind of move through this program. So as I mentioned, this is the first session of the MPN Pathways program. To view the upcoming sessions, please visit our webpage that was emailed to you. But just as a reminder, it's mpnresearchfoundation.org/MPN Pathways. The next session is titled The Life Cycle of Drug Development, and we have a date. It's going to be virtually live on November 19th from 5 to 6 p.m. We'll have Dr. Scott Weir from the University of Kansas Cancer Center here to discuss really the journey of bringing new therapies to patients. He'll share the different types of cancer therapeutic agents, the concept of cancer drug targets, reviewing the clinical trial phases and considerations, and then what happens once a drug is approved by the FDA. Today, we're going to learn about the MPN Research Foundation's mission, history, and research activities. We also will learn more about MPN resources for patients and their caregivers. You will be provided with an introduction to the 3 classical MPNs, so essential thrombocythemia, or ET, polycythemia vera, or PV, and myelofibrosis, which we'll refer to as MF. So we'll also review the different MPN risk factors, the genetic mutations, diagnosis, symptoms, and the available treatments. Since we are covering so much in our first webinar, I'm really going to encourage you to place your questions in the Q&A feature of the webinar. A member of our team, I think we have Rick, Amiel, and Kapila on standby, will be answering those questions as I present. My presentation is almost close to an hour, so I apologize that this one won't be as interactive as the future ones, but there's just so much to cover, and we want to make sure we spend enough time really digging into the really crucial parts of MPN treatment and research. If we have time at the end of the presentation, though, we will answer questions live. But any questions that we don't get to, just know I will follow up via email and make sure all those questions are answered for the entire group. But before we start, I also want to mention we are happy to help guide and provide resources and education, but please know that we have the limits where we can't provide medical advice or answer any really direct questions to your care or your diagnosis. We always encourage that those be addressed with your medical providers. So let's get started. Our first section here on the MPN Research Foundation. So we're just going to start out by talking about the foundation's history and mission. So pictured on the left here is Robert Rosen. Robert was, or we call him Bob. He was a polycythemia vera or PV patient who established the foundation by pulling together a few MPN patients back in 1999. So we are working very hard to carry on Bob's legacy and the mission of the organization, which is to stimulate original research in the pursuit of new treatments and eventually a cure for the blood cancers PV, ET, and MF, or known collectively as Myeloproliferative Neoplasms, or MPNs. So at the MPN Research Foundation, we are also committed to funding researchers in their quest to treat and ultimately cure MPNs. We are also committed to providing education and resources to patients, their families, and really the entire MPN community. We know that working together, we can change the prognosis and really create a brighter future for those people whose lives are affected by this group of diseases. So from our unique position, really at the intersection of these 3 key stakeholders, we have our patients and our caregivers, we have our researchers and our clinicians, and we have the biotech pharma industry. We facilitate a collaborative approach to research that really elevates the patient voice in the research and drug development. We want to bring disease experts together, and we want to accelerate the industry's understanding of an extremely complex group of diseases. So MPNRF has 3 unique roles in the MPN community that advance the research mission. Number 1 is research. So we're identifying, funding, and supporting novel research to really accelerate the discovery and the development of effective MPN treatments. And then we want to convene, so facilitate that global engagement across patients and caregivers, researchers, clinicians, and again, industry stakeholders. And then we want to advocate. So we want to advance patient and researchers' perspectives on the development of new treatments. To ensure that we're meeting the needs of each of these groups, we have an amazing team that is really passionate about the work that they do. So Kapila Vaidjas is our foundation CEO, and then Dr. Ram Paul there, he is our medical advisor. Christine and I really focus on patient engagement in clinical trials. So you'll be communicating probably with one or both of us at many times. And then Rick is our director of scientific strategies, who's excellent in really guiding the organization to be able to kind of go in the right direction on what research we're funding and the importance of it. So on this slide, we have our operations team, our marketing and communications, and our development and growth team, which are all phenomenal and really caring and wonderful individuals. So I hope you also have the chance to meet all of them. We have also a board of directors. So their expertise guides the direction and the governance of the foundation. It really decides on the appropriate research and patient activities to undertake. So we rely on them heavily and we thank them for all that they do. And then we have our scientific advisory board. So this board, we engage them strategically in developing a research agenda and really the effective funding mechanisms. And they're kind of all over the globe here. So they bring a lot of value to our organization. And we also have a patient impact council that actively advocates for the patient voice and perspective in all aspects that we do to promote research advances and therapies that really have meaningful benefits to patients. So this year, these individuals completed reviewing research proposals for our MPN Challenge funding. They also have been reviewing clinical trial protocols, informed consents. They participate in patient panels and focus groups to really provide their insights on MPN research. All 3 of the MPNs are represented, and this diverse group spans across the US. But what we're really hoping to do with Pathways is really to grow this army and to grow this expertise of patients and caregivers by giving you the education to be able to do kind of what they're doing on a regular basis for us. So more to come, and we're happy to get all of you involved. But over the past 24 years, we have invested $20 million in research across 105 research projects. Throughout that funding, 98 researchers have been supported in 9 different countries at 49 institutions. Our patient caregiver community is really constantly growing, and to date, we are connected and have identified over 14,000 patients and caregivers. A few examples of our ongoing research activities are listed here. So as mentioned, our foundation is funding research through various mechanisms, such as the MPN Challenge Grant and the Thrive Initiative. The MPN Challenge is our open request for proposals that allows us to really fund the most pressing MPN science. These focus areas change each round, which is usually every other year. But as we learn more about the unmet needs in the MPN research space, those focus areas shift, and we make sure that we include the patient and the caregivers' perspectives when choosing those focus areas. MPNRF funded the first study to locate and identify genes that lead to MPN driver mutations, as well as the identification of preclinical drug candidates that selectively eliminate JAK2 mutated cells. So we are very proud to be a part of advancing the treatment landscape for important discoveries for MPN patients. Our other research activities include clinical and researcher outreach campaign. We want to be sure that we're always connecting and educating our hematologists, our community oncologists, and sometimes even those primary care physicians that are out in the community diagnosing patients, as well as nurses. We want to make sure that we're always there to help them learn. We develop research events. So we have our Progression Research Network Summit and our MPN Roundtable, and then our MPN Research Foundation communications. We have a newsletter, we have social media, and we just have various other ways to communicate with us on our website. And then presence at scientific meetings. So these include ASH, EHA, ASCO, MPN Congress, MPN Horizons, etc. We go to make sure that we are bringing back the community the most up-to-date MPN research advances. So we know that uncertainty of progression and really the unpredictability of symptoms add fear and worry to MPN patients. So for this reason, we are pursuing a long-term strategy to establish a multi-data source registry of MPN patients. So patients and their participation will really be crucial in the success of this project. But our goal with this MPN progression registry is to facilitate high-quality observational research to improve clinical definitions of MPN disease progression by defining risk biomarkers, enabling the identification of clinical trial endpoints, and really enhancing the standard of care for our MPN patients. We really need a better picture of the MPN patient journey and the experience to really have some of that data to move the research forward. But we do hope to start recruiting and bringing in patients by next year. We're so glad that you're connected to us because we'll be able to provide those updates as they are available. The MPN community is active and expanding, which I'm sure many of you know. So although the focus of the MPN Research Foundation is funding research, we recognize that patients need all kinds of information and support. So we are really pleased and proud to recognize a growing number of organizations in this space. And we're committed to working together with these organizations to bring the best and most complete resources to the MPN patient community. So Christina and myself are happy to navigate you to the right resources. Just reach out and we'd be happy to make that introduction and that connection. One of the partners that we really would like to highlight is the MPN Advocates Network. So this Pathways program is in collaboration with this group to ensure that we are educating patients and caregivers really globally. So the mission of the MPN Advocates Network is to enhance the ability of global patient advocacy to improve patient care, quality of life, and patient empowerment for all patients who have been diagnosed with an MPN and their caregivers. So this group has close to 50 members representing their countries across the globe. So if you are some of our global participants, know that there are resources out there for you that don't include just what's in the United States, and we are happy to connect you to those individuals at any time. So please let us know. We'll get you connected to the Advocates Network and then somebody locally where you are. So I would like to take a few minutes to highlight some of the resources for our patients and our caregivers. We encourage patients to visit our website to access all these resources. And for those that are interested, we do also encourage you to subscribe or join our community to receive our newsletters, our Under the Microscope, or our print newsletter, which is one that we send out every quarter. Other timely communications about what's really happening in the MPN community. And we do have that presence on social media platforms, and we encourage engagement with other patients and caregivers on those platforms. So it's a great way to have immediate kind of engagement with individuals like yourself. So patients can also download the National Comprehensive Cancer Network NCCN guidelines. I do have a whole slide dedicated to that, so I'm going to wait to kind of explain what that is, but that's something we definitely want patients to look at. And then we have ETPV and MF education on our website, but we are always working on bringing engaging and comprehensible updates to the education on our website as they become available. We also have the MPN Patient Bill of Rights. So this MPNRF Patient Bill of Rights helps establish and promote awareness of core elements central to quality MPN patient care. And then we have our clinical trial finder. This tool is housed on our website to assist MPN patients with finding a clinical trial that matches their diagnosis and treatment history. But like I said, Christina also is a highly trained clinical trial nurse that would be happy to kind of connect you to the right resources to help you find that clinical trial that's right for you. We have patient stories, so a variety of MPN patient stories and caregiver stories actually are available to read on the website to learn more about those who have similar experiences. And then where you can find local support or online support, there's a whole page dedicated to helping patients and caregivers find those groups or individuals to talk or connect with. And then financial resources to help patients with the cost of treatment and care. So this information was also emailed to you in the pre-email. I just wanted to make sure that you had all those links. And if you have any questions, please let me know. And then there's also a page dedicated to how to find an MPN specialist or how to go about that second opinion. So for those that are interested in that, we highly encourage you, or if you have any questions related to what your care involves and need a second opinion, please don't hesitate to reach out and do that, and we can help identify providers that are available. So back to the NCCN guidelines, we really encourage patients and caregivers to have a copy of this. So this document was recently updated and released June of this year. We did share the link in the pre-material, but physical copies can be ordered through NCCN directly, or they also easily can be ordered through Amazon. But this guide is really expert, comprehensive information presented in plain language with visuals, charts, definitions to really empower MPN patients and their caregivers to talk to clinicians about the best treatment options. So these guidelines are also available in many languages. We have English, Russian, Arabic, Chinese, French, Hindi, Portuguese, and Spanish. So it's a nice new development that they've been creating these in additional languages for our global friends. One thing I do want to make sure that you all have, so I'll pause here for a minute, which you've been getting emails from me, so I'm sure that you already have it, but please email me at patientengagement@mpnrf.org with any questions or insights, or if you want to share your experience. I'm always here to listen and to help you find kind of the best answers and resources as you kind of experience and come across different challenges in your MPN diagnosis. Okay, so that's the first portion. We like to do a wrap up here just because I know it's so much information at once. But our foundation really strives to identify, fund, and support novel research to accelerate the discovery and the development of effective MPN treatments. We provide the MPN community with the latest news in MPN research, drug discoveries, community events, support groups, and educational resources. We want to connect with you so you can be part of our coordinated effort to find new treatments and eventually a cure for MPNs. And our patient and caregiver resources can be found on our website. That includes support groups, MPN specialists, NCCN guidelines. And then know that the MPN community, again, is active and expanding. We're happy to be your navigators and find you the right organization to connect with as you come across different challenges or need additional resources. And then again, email me at any time, and I'll be happy to connect you to opportunities as they arise. Okay, so now we're going to get into more of the MPN disease education. So I first want to provide a high-level definition of myeloproliferative neoplasms, or the MPNs, and their different types. So when this is broken down, myelo, which means to do with cells from the bone marrow, proliferative, which means an overproduction, and then neoplasm, which is an abnormal growth of cells, and in this case, blood cells. Just a high-level introduction, know that MPNs are a type of blood cancer. MPNs can be slow-growing. They can also be challenging to diagnose. MPNs can progress. MPNs can and do have sometimes distressing symptoms, and really research is crucial to improve and extend the lives of these patients. So MPNs are classified based on the presence or absence of a chromosomal abnormality called the Philadelphia chromosome. So the three most common Philadelphia chromosome negative MPNs are MF, ET, and PV. So myelofibrosis is a rare type of blood cancer characterized by the buildup of scar tissue. As the scar tissue increases, the bone marrow cannot make enough healthy blood cells. So MF is when there's an overproduction of fibrosis that is really crowding out those healthy blood cells in the bone marrow. MPN patients or MF patients can It can occur in patients with no prior history of an MPN. We call that primary MF, or as a progression from PV to ET, which is then called secondary MF. Polycythemia vera is characterized by an elevation of red blood cells. So PV patients also often exhibit high white blood cells and platelet counts. Essential thrombocythemia is a rare type of blood cancer characterized by the overproduction of thrombocytes or platelets. So changes in the production of these cells really lead to the numerous symptoms that our MPN patients experience. So sometimes chronic myeloid leukemia, it's often in the MPN category, but it's often discussed by itself. So its treatment is based on a cancer marker that other classical MPNs do not have, which is the BCR-ABL fusion gene. So for this reason, right now, the foundation is just really providing research and education for the 3 classical MPNs. All right, so looking at MPN diagnosis, we want to just share with you what should be included in that. So we're looking at a physical exam. So this may include check of your vital signs, such as your pulse, your blood pressure, along with checks of your lymph nodes, palpation of your spleen, and your abdomen. Looking at blood tests. So one test looks at your complete blood count, or your CBC. So in this lab, red blood cells, white blood cells, platelets, and hematocrit are examined to really monitor a patient's MPN disease. When we look at imaging tests, so that includes x-rays, ultrasounds, and MRIs, these may help doctors determine more information about patients' MPNs. So your doctors will review the scans to look at the following, which may lead to this diagnosis. So lymph node enlargement, generalized increased bone density, enlargement of your liver, or splenomegaly, which is the enlargement of your spleen. So bone marrow biopsy and aspiration. So this is really used to solidify a diagnosis. A sample of your bone tissue and bone marrow from your hip bones is taken out using a needle, pictured kind of here. Except somebody mentioned there, like that seems like a small needle for the pain that I felt. But know that there are nurses and there are physicians that are very trained in collecting these samples. But another tape and needle may be used during this procedure to take really the liquid sample of the bone marrow, but these samples are studied in a laboratory to really determine the number and the types of cells found. Biomarker and molecular studies are very sensitive, specific tests used to isolate specific gene mutations that are associated with MPNs. These tests can be performed on bone marrow aspirate, and in some cases on peripheral blood or the blood that's drawn from your arm or your hand. A PCR test, so this type of test is used to determine the presence or the absence of a specific or singular gene mutation. But a newer technology called next generation sequencing, or NGS, can test for multiple genetic markers at the same time. So it may be used instead of a single molecular test. NGS testing is recommended to assess for prognosis. If it wasn't done before, a prognosis really predicts how the cancer will behave and respond to the treatment. During diagnosis, healthcare professionals also ensure that no other blood cancers are present, which this could include myelodysplastic syndromes or other leukemias. So many MPNs are discovered through routine blood tests. When your PCP may notice some abnormalities on your CBC, other times patients will have had a blood clot, and through that workup, determine that the cause of that blood clot was an MPN. Some of the diagnostic challenges that patients are facing is patients may not experience any signs or symptoms, so there is a delay in diagnosis if routine blood isn't drawn. Signs and symptoms could have other causes, so those need to be ruled out. And then ET, PV, and MF have similar test results, so to distinguish between the two can be a little bit challenging at times. And then bleeding can change test results or even hide a correct diagnosis sometimes. And then I'm sure, as you all have experienced, not all healthcare providers have diagnosed or even treated a patient with an MPN. So we're trying to continue to bring awareness and knowledge to our PCPs, our community oncologists, just to make sure that patients don't experience that delay in diagnosis. So according to the Surveillance Epidemiology and End Results, or the SEER program of the National Cancer Institute, this is old data and this is all we have, but as of 2010, the high range estimate is that 20,000 people a year get an MPN, and there's approximately 300,000 people living with an MPN in the US. We do believe that number is much larger today, and we also believe that there are many patients living with an MPN who just have not been diagnosed yet. Okay, so bear with me. I'm going to really get into genetic mutations involved with MPNs, but a mutation or a series of mutations in the DNA or our genetic material of a blood stem cell can cause an MPN. So a mutation is any change in the sequence of the DNA of the cell. Genetic mutations may be caused by mistakes during cell division or exposure to DNA damaging agents that are in the environment. But in 95% of cases, the mutations that drive the development of an MPN phenotype are accounted for by 3 genes, which are JAK2, CALR, and MPL, right here. So, however, not all people with an MPN have an identified driver mutation. In some cases, the cause of these mutations to the blood stem cell is unknown. Some may have heard of triple negative MPNs, which means an individual does not have one of the 3 listed mutations. The MPN gene mutations or mistakes in cell division really occur during a person's lifetime or after birth, which we refer to that as acquired or somatic mutations. However, recent research has also shown that MPN mutations have been found in utero or before birth. But know that the longer we live, the more exposure we have to things that can cause those somatic or acquired mutations. Mutations typically are not common in patients under 40, but we know there's several patients out there under 40 with MPNs, but the likelihood increases significantly after the age of 60. In rare cases, very rare cases, MPNs can run in families. This is rare, so it's generally not something most people with MPNs need to feel concerned about, although research is still ongoing and there is an increased interest in this topic because there has been some correlation. But there's also research being done to see if individuals of certain heritage are particularly susceptible to MPNs. These results of MPN driver mutations are really useful for diagnosis and treatment planning. They can help identify MPN subtypes or secondary mutations. They can help grade bone marrow fibrosis and assess patients' prognosis. So really knowing the results of your NGS testing is super important, and I encourage all of you to review that. So our JAK-STAT pathway here, so this is involved in normal hematopoiesis, or what we call our blood cell development and our immune function. So mutations in the genes mentioned in the previous slide may cause the pathway to really always be on. So when this pathway is always on, this leads to an overproduction of blood cells or clonal expansion and cytokines. So cytokines are chemical substances that contribute to cell growth and are associated with inflammation. The increase of these blood cells and the excess of cytokines largely explain the symptoms that are commonly seen in MPN patients. So the interruption of this JAK-STAT pathway using a JAK inhibitor or a JAK kinase inhibitor is a therapeutic strategy used to treat MPNs, which we'll kind of review those later on in this presentation. But that's your overview of the JAK-STAT pathway. All right, let's move on to symptoms. So MPNs do cause a wide range of symptoms, but despite this wide range, there are basically 3 types of symptoms, and doctors and your providers plan treatment based on these types. So microvascular symptoms. These symptoms are caused by slow blood flow in small blood vessels called capillaries, which cause headache, blurred vision, dizziness, numbness and tingling in the limbs, poor concentration, or sleep problems. And then enlarged spleen symptoms. So patients with MPNs, the bone marrow may be unable to make those blood cells. So the spleen is a very common backup to the bone marrow for the blood cell production. So when the spleen starts to supply the body with blood cells, it enlarges or it gets bigger. It causes symptoms because it presses against other body parts. So you may feel full quicker when you're eating. You may experience shortness of breath or cough. There may be abdominal pain or really decreased activity. Some of our constitutional symptoms that MPN patients experience are really the result of a condition that is affecting the entire body, such as cancer. So these are very general and can be caused by more than one factor, one being high levels of cytokines. So cytokines trigger inflammation. So another symptom could be fatigue, weight loss, bone pain, and itchy skin. The MPN-10 assessment is recommended in the NCCN guidelines for the assessment of symptom burden at diagnosis or baseline, and then monitoring the symptom status during your course of treatment. Patients and families can find this online, fill it out, and really keep track of their symptoms to discuss with their provider at every single visit. So the top 10 symptoms of MPNs that patients experience are ongoing extreme tiredness or fatigue, feeling full quickly when eating, pain in the belly or the abdominal area, inactivity, unable to focus for an extended period of time, night sweats, itchy skin, bone pain, fevers, or weight loss. I just want to take a minute though to know that every patient is different. This is certainly not a comprehensible list. We'll address more symptoms as we go into each of the MPNs, but always report every symptom that you're experiencing, because even if it's not on this list, it could be associated, and no symptom we want to disregard. Okay, so to wrap up this part 2 of this webinar, the 3 classical MPNs are ET, PV, and MF. You know, the MPNs are a type of rare blood cancer. MPNs can be slow growing, or what we call a chronic cancer. Their accurate and timely diagnosis is so important. MPNs cause a wide range of symptoms. In 95% of cases, MPNs, the driver mutations that drive really the development of an MPN phenotype, are accounted for by 3 acquired or somatic mutations in 3 genes. And we have JAK2, CALR, or MPL. And then know that ET and PV can progress to MF, but MPNs can also progress to acute myeloid leukemia. So it's so important for you to discuss your labs and your symptoms with your provider at every single visit. Okay, so first up, we're going to move to a deeper dive into the 3 classical MPNs, the first one being essential thrombocythemia, or ET. So essential thrombocythemia is a rare type of blood cancer characterized by the overproduction of thrombocytes or platelets. So an elevation of platelets can lead to blood clots, or in some cases, increased bleeding. So the criteria for ET diagnosis includes high platelet counts, so greater than 450,000. Know that normal platelet counts in adults range from 150,000 to 450,000 usually. And then megakaryocytes. So megakaryocytes are rare cells that are found in the bone marrow. They are responsible for everyday production and release of millions of platelets into your bloodstream. So another criteria of ET is really having a high number of abnormal megakaryocytes in the bone marrow. And then ET can only be diagnosed after all other blood cancers and MPNs have been ruled out. And then the 4th criteria is having that JAK2, CALR, or MPL mutation, but it is not required for diagnosis. Now that JAK2 is the most common, with CALR being the 2nd, but 1 out of 10 ET patients, for those who don't have those 3 mutations, they're called triple negative ET. So ET symptoms vary by patient, and some ET patients may not experience any symptoms really at all. But the common ET symptoms relate to a few things, one being the small vessel disturbances, which may include headache, vision disturbances, or what we call silent migraines, dizziness or lightheadedness, coldness or blueness of your fingers or your toes, burning, redness, and pain in your hands or feet. And then when bleeding is present as a symptom of essential thrombocythemia, it can manifest as easy bruising, nosebleeds, heavy menstrual periods, gastrointestinal bleeding or blood in your urine. Thrombotic complications can also occur, which those could result in a stroke, a TIA or a transischemic attack, a heart attack, a DVT, or a deep vein thrombosis, or a pulmonary embolism with a blood clot in your lung, and then blood clotting also in unusual locations such as the abdominal veins. So ET risk factors, we'll start with one. Gender. Women are 1.5 times more likely than men to develop ET. People older than 60 are more likely to develop the condition, although 20% of ET sufferers are under the age of 40. JAK2 mutation, so approximately half of all ET patients have the mutation of the JAK2 gene in their blood-forming cells. We talked about this it leads to the hyperactive JAK signaling, causing the body to make wrong number of blood cells. And then CALR, so nearly a quarter or 24% of those diagnosed with MF and ET have a mutation called calrictalin or CALR. So looking at the goals of treatment for ET, we want to be able to reduce the risk for blood clots. We want to reduce the risk of cardiovascular and cerebrovascular events. We want to reduce the risk of bleeding. We want to be sure we're managing those disease-related symptoms. And we want to reduce the risk of leukemic or transformation to myelofibrosis. And most importantly, we want to improve the quality of life for these patients. So for ET treatment, a tool called the International Prognostic Score of Thrombosis is really used to determine the risk level. So treatment options look at the different risk levels. So individuals with a very low risk of blood clots, so that means they're under the age of 60 and they have no history of blood clots and no JAK mutation. Treatment may include managing their cardiovascular risk factors, such as not smoking, exercising, managing your blood pressure, managing your blood sugar, weight, looking at different diets and your nutrition. Aspirin may be added to these patients if they're experiencing some of those microvascular symptoms we discussed. And then aspirin is always added to the treatment plan for individuals at low risk with a JAK2 mutation. Those who are at intermediate risk of blood clots, which means 60 or older, no history of blood clots, and no JAK2 mutation, a treatment plan includes, again, managing those cardiovascular risk factors and aspirin. So those that are at high risk, which means they're 60 or older, have a high risk of blood clots and have a JAK2 mutation, along with managing those cardiovascular risk factors, aspirin may be prescribed, but you also may be prescribed hydroxyurea, interferon, or eneglaride. So aspirin prevents clots by making the platelets kind of less sticky. Hydroxyurea works by suppressing bone marrow production, including platelets. Eneglaride works by inhibiting the maturation of platelets from those megakaryocytes that we discussed. And interferon works by preventing abnormal or malignant cells from increasing in numbers. And we do also encourage all ET patients to look at the available clinical trials and have those discussions with your provider to see what's available for you. So to wrap up the ET section, it's super important to prevent blood clots. Your provider should be assessing and helping you manage those cardiovascular risk factors that can be changed. It occurs more frequently in women or those of, over 60. ET treatment is based on your risk factors, or your risk of clots, which is your age or your prior history of clots, and whether or not you have a JAK2 mutation. So ET-approved therapies or treatments in the United States include aspirin, hydroxyurea, PEG interferon alpha-2A, and eneglaride. Also know that clinical trials are available for ET patients. And most importantly, it's always crucial that you discuss your labs and your symptoms with your provider. Okay, so now we're going to do our deeper dive into polycythemia vera. So PV is characterized by high hemoglobin, hematocrit, or red blood cell mass. So in males, this means that the hemoglobin is going to be greater than 16.5, and in females, it's going to be greater than 16. The hematocrit is greater in then 49% in males and 48% in females to be considered for PV. Red cell mass is the volume of red blood cells. So red cell mass, it's not often used to diagnose MPNs, but if it is high, then it's 25% greater than the normal value. The second criterion for PV is having a high number of bone marrow cells compared to fat cells, which is called hypercellularity. So hypercellularity consists of those myeloid cells. And the third criterion is a JAK2 mutation, but it's not required for diagnosis. Almost all PV patients have a JAK2 V617F mutation. The few without the JAK2 exon will have a JAK2 exon 12 mutation instead of the JAK2 V617F. If there's no JAK2 mutation, PV can be diagnosed if the first two criteria are met and you have low erythropoietin levels in your blood. PV patients also may have high white blood cells, neutrophils, platelets, and sometimes LDH levels. PV patients may also have low iron levels. That's not a diagnostic criteria, but if you're having phlebotomies, it's really encouraged that you're also making sure you're following your iron levels. So PV symptoms can range from none to severe and can again be grouped together based on the underlying cause. So too many blood cells, so thickening of blood, can impair oxygen delivery to those vital organs. So those symptoms include fatigue, headaches, numbness or tingling in the fingers and toes, double or blurred vision, ringing in the ears, or difficulty concentrating. Pain, swelling, redness in the arms or the legs, and really redness of the face and the hands. When we look at enlarged spleen, so again, we have that abdominal pain under the ribs on the left side, and that early feeling of fullness when you're eating. Symptoms associated with thrombosis or a blood clot, so that could be chest pain, shortness of breath, nausea, that may be indicative of a heart attack. A severe headache with impaired thinking or speech, weakness in the arms and legs, that may be indicative of a stroke, and it's very important to seek emergency medical attention for those sort of things. Overproduction of inflammatory cytokines, so this includes itching, burning, feeling in the skin. PV patients really report this kind of especially after getting out of a hot shower. Flushing of the face, bone pain, and night sweats. So risk factors associated with PV include gender. So men are slightly more likely than women to develop PV. And then age, people over, again, 60 are most likely to develop the condition, though it may occur at any age. When we're looking at the environment, exposures to intense radiation may increase the risk for the condition. It also has been suggested that exposure to toxic substances may increase the risk for blood cancers. And then a JAK2 mutation. So we know that approximately 95% of all PV patients have a mutation of the JAK2 gene in their blood-forming cells. So this mutation leads again to that hyperactive JAK signaling in the pathway, causing your body to make an abnormal or wrong number of blood cells. PV treatment goals. So again, reducing the risk for blood clots, reducing the risk for cardiovascular and cerebrovascular events, reducing the risk of bleeding, managing those disease-related symptoms, reducing the risk of transformation to myelofibrosis or leukemic transformation, and ultimately, we want to make sure that we're improving the quality of life for these patients. Okay, so treatments available in the United States. Patients with PV are put into one or two groups, low risk or high risk for blood clots. So people at low risk do not have any key risk factors, while people at high risk have either or both of the key risk factors, which are one being over 60 and the other one is having a prior blood clot. For individuals that are at low risk, treatment may include, again, managing those cardiovascular risk symptoms. But also it includes aspirin and could include phlebotomies to maintain a hematocrit below 45%. For those who do not know what phlebotomies is, that's the removal of blood through your arm. It's almost like donating blood, but with fewer blood cells, the blood is thinner and it flows more easily. So phlebotomy helps by improving symptoms and really reducing the risk of blood clotting. For those at high risk or who have moved into the high risk category with symptoms, which is 60 or older and have a history of blood clots, along with managing their cardiovascular risk factors, aspirin and phlebotomies, they may also be prescribed a cytoreductive therapy to reduce some of those blood counts. So the provider will really determine which therapy to prescribe, but this could include hydroxyurea or ropeg interferon or peg interferon. So hydroxyurea, again, works by suppressing the bone marrow production, including red and white blood cells and platelets. Peg interferon works by preventing abnormal or malignant cells from increasing in numbers. And then ropeg interferon, like peg interferon, but it works by blocking the signals that cause cancer cells to multiply. If patients have inadequate response or loss of response to the therapies, the provider may switch to one of the other cytoreductive therapies, or ruxolitinib or Jakafi may also be prescribed for PV patients who have a resistance or intolerance to hydroxyurea. So ruxolitinib is a JAK inhibitor which is used to block really the process of those faulty genes and help ease some of the PV symptoms. PV patients also are encouraged to follow available clinical trials because there are many out there, and please discuss those with your provider. So to wrap up the PV section, it's important to prevent blood clots. Your provider should assess and help you manage those cardiovascular risk factors that can be changed. PV occurs more frequently in men and those over 60. PV treatment is based on your risk of clots, so your age and your prior history and symptoms. PV-approved treatments in the United States include aspirin, phlebotomy, hydroxyurea, ropeg interferon, peg interferon, and or ruxolitinib. Phlebotomy is the removal of blood to reduce the number of blood cells and reduce your hematocrit. Clinical trials are available. And again, it is very important to discuss your labs and your symptoms with your provider at every visit. Okay, so your doctor will see you and do tests frequently, or should be doing tests frequently to monitor your PV or ET. I just want to bring up that some signs that your disease could be changing or could be progressing includes increased or decreasing blood counts, increase in symptoms, a new decrease in appetite, or an enlarging spleen. Some of these can be caused by the medication side effects as well, but never take anything for granted and just totally share all of your symptoms with your provider, even a new symptom, because we want to make sure that we're catching any signs of progression very early. This is one reason really people living with an MPNs undergo this regular blood work, and they're really encouraged to keep a history of the symptoms to help improve their quality of life. Standardized symptom test assessments forms are very helpful for both the patient and their care teams, but know that they're not all inclusive. So just be aware of the changes and have the information to watch them and track them over time. All right, so last of the classical MPNs is myelofibrosis. So myelofibrosis, or MF, is a type of cancer that starts in your bone marrow, the spongy tissue inside your bones where most of the blood cells are made. So this includes your red blood cells that carry oxygen, your white blood cells that help fight infections, and platelets that help blood clot. With MF, your bone marrow makes abnormal blood cells as well as fibers that can really clump together in the scar tissue. So as more of that scar tissue forms in your bone marrow, it has less room to make new healthy blood cells. So this leads to symptoms and complications. MF can occur without a history of an MPN, so we call that primary MF, but it also can occur as a progression from PV or ET in a small percentage of patients, which we call that secondary MF. Bone marrow grade refers to the degree of abnormality in the bone marrow cells or the level of fibrosis or scarring observed under a microscope compared to really the healthy cells. So pre-fibrotic or early MF is grades 0 and 1, and advanced MF is 2 and 3, grades 2 or 3. And then know that really symptoms and complications are increasing the higher the grade. Okay, so myelofibrosis symptoms as well as complications. So some people who are living with MF may have no symptoms, especially early on, but over time, the lack of normal blood cells can weaken your immune system and can cause symptoms and complications or additional problems. So most symptoms and complications happen when your bone marrow cannot make enough healthy red blood cells, white blood cells, or platelets. So when we're talking about anemia, that means not enough healthy red blood cells. Your hemoglobin may be low, which leads to weakness, fatigue, shortness of breath, pale skin, and or confusion. And then neutropenia is not having enough white blood cells or those neutrophils. This can lead to problems fighting infections. Thrombocythemia, which means not enough platelets. This can lead to easier bleeding and bruising. And then thrombocythemia, or too many abnormal platelets, this can lead to blood clots and or stroke. So symptoms can also happen when your spleen or your liver pitch in to help you make blood cells and become swollen or enlarged. So these can include stomach pain, back pain, bloating, and feeling full. Know that blood transfusions or additional medications may be necessary to combat some of those anemia and low platelets in patients. So it's not always known exactly what causes MF or why some people may develop it while others do not. But again, there are a few risk factors that could increase your chances. So myelofibrosis is often diagnosed in people over 60, although there are known cases of myelofibrosis in the young. Again, chemical or environmental exposures, so exposures to benzene, certain solvents or pesticides, and heavy metals such as mercury or lead have been associated with changes in the bone marrow stem cells and or the bone marrow microenvironment. Approximately 50 to 60% of people with MF have a mutation of the JAK2 gene within their blood-forming cells. About 24% of people with myelofibrosis have a mutation called calreticulin or CALR, and between 5 to 10% of patients have a mutation in another gene called MPL, which also affects the JAK signaling pathway. As mentioned, MF can progress from ET or PV, but progression from ET to MF is less common. Treatment is based on really how aggressive the MF is predicted to be. So age, symptoms, blood work, and molecular testing really all factor into the risk level. So on the right here, there are many systems and scales used to determine the risk. These are all in the NCCN patient guidelines. So I highly suggest you kind of look at all of those to determine risk and work with your provider. For a small number of patients, 10 to 20%, MF can transform to acute myeloid leukemia or AML. AML is a serious blood and bone marrow cancer. When AML does arise from MF, it progresses quickly and it can be difficult to treat. So as mentioned, this is why our foundation has a really strong interest in studying progression in MPNs and really helping support funding that helps combat this. But again, please always report your symptoms and discuss your blood results with your provider. So MF treatment goals include managing disease-related symptoms, improving those blood counts, preventing or delaying progression to advanced MF or leukemia, and ultimately improving the quality of life for patients. So MF available treatments. Within the last couple years, several have become FDA approved. So we want to kind of review all of those today. But I encourage each one of you to really look into each one of those specifically to learn more. But lower risk patients, so those are patients that have no symptoms. Sometimes providers are having the patient do a watch and wait. So lower risk MF is likely to be stable or progress slowly. They're also encouraged to look into different clinical trials that are available for low risk patients with no symptoms. But watch and wait doesn't always mean that you're not doing anything. You can be improving your diet. You can be improving your exercise. You can just do things that are continually make your whole body healthy. Those patients that are at low risk with symptoms, again, you could look into a clinical trial, but the available treatments are hydroxyurea. So remember, hydroxyurea is a cytoreductive therapy that helps reduce symptoms by help controlling blood counts. PEG interferon alpha 2A, so the interferons stimulate the immune system and can help, have been shown to slow the progression of myelofibrosis. Ruxolitinib and momelotinib. Those are both JAK inhibitors. Remember, JAK inhibitors stop the JAK and reduce the number of new blood cells that are being made. These can reduce the spleen size and improve MF symptoms. JAK inhibitors are pills that you do take at home. And then for our higher risk patients, so those who have platelets less than 50,000, they may be referred to a bone marrow transplant specialist, but also available treatments include pacritinib, momelotinib, or again, they're encouraged to look into a clinical trial. For patients who have platelets greater than 50,000, again, they could be referred to the bone marrow transplant specialist, but ruxolitinib, fedratinib, momelotinib, pacritinib, or again, a clinical trial may be a part of their treatment plan. And no, just so you can associate some of the brand names, ruxolitinib, Jakafi, momelotinib, Ojjaara, pacritinib is Vonjo, and fedratinib is Renovic. So those are the available treatments that have been approved in the US. An allogenic bone marrow transplant forms a new healthy bone marrow that makes healthy blood cells. So there are significant risks with this procedure. Therefore, although a bone marrow transplantation offers a potential cure for MF, this procedure is available to a small portion of adult MF patients. Doctors and your providers will really determine on a case-by-case basis those who are candidates for the stem cell transplantation. For those who are eligible, the stem cell transplant may begin shortly after diagnosis, and looking for that match may begin immediately, but high-risk MF patients should be referred to a transplant specialist to have that discussion. This specialist will really assess if they are a candidate for a transplant and really what those donor options look like. So donors may be related, brother, sister, child, parent, or they may be an unrelated volunteer donor. Patients who are not candidates for an allo stem cell transplant are encouraged to participate in clinical trials and look into the different treatment options that we discussed in the previous slide. So for the MF wrap-up, in myelofibrosis, your bone marrow makes abnormal blood cells as well as fibers that can clump together into scar tissue. As more scar tissue forms in your bone marrow, it has less room to make those new healthy blood cells. MF can occur in people with or without a history of an MPN. We call that primary MF. PV and ET can progress to MF over time in a small percentage of patients, so we're calling that secondary MF. Bone marrow grade refers to the degree of abnormality in the bone marrow cells or the level of fibrosis scarring. So prefibrotic or early MF is grade 0 and 1, and advanced MF is grade 2 or 3. Most symptoms and complications happen when your bone marrow cannot make enough healthy red blood cells, white blood cells, or platelets. Treatment is partly based on how aggressive an MF patient is predicted to be based on those scales and systems. Available treatments for MF in the United States are a bone marrow transplant, ruxolitinib, PEG interferon, hydroxyurea, pacritinib, momelotinib, and fedratinib. Patients may also need blood transfusions or supportive medications to help stabilize blood counts. And providers will really determine on a case-by-case basis who are candidates for an allo stem cell transplantation. And always know that clinical trials are available and should be looked and discussed with your provider. Okay, so thank you for hanging in there with us. I know that was a lot of information. This recording will be provided so that you can go back and listen to different sections and also the pre-material that was sent for you. And as always, send me any questions, but I do want to take a moment to thank our sponsors that are listed here on this slide. The MPN Pathways program is being done because of these generous sponsors, and we can't thank them enough for being committed to the MPN space and the education of our patients and our caregivers. You will receive an evaluation for this session. Be sure that you do complete that because that gives you credit towards your certification at the end. So know that that link will be emailed to you very shortly. Again, a reminder, the next session is November 19th from 5 to 6 p.m. We are going to have Dr. Scott Weir talk about the life cycle of drug development. You'll be sent the link for the registration for the live session in the post-event email. Know that all participants must register for each individual webinar to gain access to the live event. But this, again, will be recorded and put on our webpage so you can follow up later if you're not available on November 19th. And then we also want you to kind of be on the lookout for our MPN patient and caregiver unmet needs assessment and patient and caregiver journey forms, which are going to be coming within the next couple months. The goal of the unmet needs assessment is to understand MPN patients and caregivers' current perspectives and perceptions and really share that information broadly with the MPN community. Through this assessment, we hope to identify what resources, services, and informations are known and their perception of them, identify some of the support groups and the support group's leader, and really identify the level of utilization, ease of access, and perceptions of current resources, services, and informations, and really looking at the different gaps of care. This survey or assessment will approximately take 20 minutes of your time, but your voice is really essential into recognizing and creating solutions for those unmet needs. And again, we'll also be sending you information on how to update your MPNRF patient caregiver journey for our records to be able to match you to unique opportunities based on your individual experiences. And so with that, we're going to conclude our first session. Thank you so much for your attention. Please know you can email me at any time at patientengagement@mpnrf.org. We are here to answer your inquiries and anything that you may have. But thank you again for participating in the MPN Pathways program. It's really crucial to include your voices to impact the research that's being done in the MPN community.